Here we go. Last half of the last lecture for you for this class. Woo! Get excited. Healthcare. Economics of healthcare delivery system. There are a few things that affect. Now, obviously, healthcare costs are going up, right? They just are. They always have been. They always will, probably. Let's get rid of this. We're not going to talk about this anymore. Well, what's making those healthcare costs rise? We've kind of touched on it a few times, but let's go over them in greater detail. There's intrinsic and extrinsic factors. Intrinsic, extrinsic. Internal, external. What are some of the intrinsic or internal factors? What are the factors of the within the system, within the patient? Well, population characteristics. What are some of the population characteristics? Aging is a big one. Healthcare demand. What do we mean by healthcare demand? Well, when was the last time you watched TV and saw a commercial for Humira or Plavix or Cialis or, just about anything? Those commercials drive demand. People go to their doctor and say, I want that drug because I saw it on TV. Drives costs up. Employer-paid health insurance. Remember we talked about it where if you never saw the bill, what would stop you from wanting that iPhone every time a new one came out? With employer-paid health insurance, you don't see most of the bill. You don't. You see what portion of the premium you pay, and you see your out-of-pocket costs, but that's a small fraction. I worked for an health insurance company, and I was just absolutely dumbfounded when I saw premiums for people for just standard insurance, standard coverage, but family premiums of $1,500 and a month. $1,500. It's a lot of money. So that's for private when you go out and buy your own insurance. But employer-paid insurances are about the same. But you don't see all that. So it seems like it's no big deal. What about some extrinsic factors? Well, technology. I think I mentioned earlier, Green Bay has 11 MRIs. It's a lot of machines. You'd think that would mean competition would drive prices down, but what happens is more people are urging doctors to order them, and prices go up. Prescription drug costs. Oh my. Huge. I have asthma, and back when it was bad, when I was overweight, I was using Advair twice a day. That's a little discus, open, inhale it. $400 a month. $400 a month. On the other hand, breathing is wonderful. So, prescription drug costs. How can we help that? How can we help patients with that? Encourage our doctors to write prescriptions for generics. Have them write prescriptions for medications that Walmart has on their $4 list. Workforce costs. Employees are expecting more money. They expect more money. More money goes out. Hospitals have to charge more. It is a vicious circle. So nurses need to have good clinical skills, but good business skills to help reduce where we can. Talk to our doctors. Make sure they're prescribing generics. Make sure that we are working efficiently, not just effectively, which means charting as you do it rather than waiting to the end of the shift and then spending 30 minutes or more in overtime charting. Calling in sick appropriately. Now, I realize calling in sick sounds like a crazy way of saving money, but how effective are you when you're working sick? And then maybe when you take a day off, you have to take an extra day off because you really got very sick, or you got a coworker sick. We have no effect over the aging population. We can't control that. As nurses, we really can't control healthcare demand, but we can educate. We can teach our patients that the medication they're on now, if it's working, stick with it. You don't have to change just because you saw a new ad. Employer-paid insurance, we can at least acknowledge the costs that are there. Even if we don't have to pay it, we should understand that there is money being paid for that, and there is a value out there. Intrinsic and extrinsic factors. That will help us be more business-like. Now, what is economics? Economics has a specific definition. Economics. The allocation of scarce economics is the allocation of scarce resources. Politics is influencing the allocation of scarce resources. You see how they are combined? They are tied. Economics is how allocation of scarce resources, and we talked about what does scarce resources mean? Money. Money, 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 money. So politics and economics, very tightly interconnected. Healthcare is a limited resource. Choices have to be made. Sometimes they're hard choices. So what do we have to think about on choices? Well, if you only have $5 in your pocket, you're at the grocery store, your wife or husband told you to bring home toilet paper and milk, and the latest National Enquirer, I don't know, whatever. How are you going to spend the money? Toilet paper, milk, or, you have to make choices. You have a limited budget. Well, so does the government. Because the government gets the money from me and you and you and you and even you back there. So since there's a limited budget, we have limited money to spend. I know that sounds crazy saying that the government has limited money to spend because they seem to spend constantly. The U.S. spends 16% of everything they spend is on health care. 16%. Federal government is the largest purchaser of health care through the Medicare program. The needs of the population are not being met. And hopefully the Obama's Affordable Care Act will help that. But right now, we spend one out of every $5, one out of every $6, one out of every $6 we're spending on healthcare, and it ain't all that. We're not, and our longevity is not the best in the world. Our child mortality is not the best in the world. You'd think it would be, but there are many countries that have far fewer birth deaths than our country. So again, we need to figure out what's going on and how can we fix it. When we're spending one out of every $6 on healthcare, eventually rationing might come into play. Now, Americans tend to hate rationing. Nobody wants to be told how much you can do and how much you can have. Nobody. But at some point, someone has to make a decision. Who gets what? I don't want that job. So how do we choose? How do we make choices? Well, it's very similar to the rights of medication, but we want to make sure we provide the right care. The amount, the provider, and the setting. What does that look like to you? We want to provide the right care. So we want quality care, but only what's needed. By a specific doctor and in the correct setting or place. HMO, right? Good quality, but only what is really needed by a specific person, not just anybody, but the gatekeeper, and in the correct setting, in the network hospital, not the hospital across the street, or not that cancer clinic across the country. So if we can apply HMO practices nationally, we will start reining in some of the healthcare costs that are escalating. Now, let's talk about allocation. Allocation, remember, is spreading. Who decides who gets what? And is healthcare a right or a commodity? What's a commodity? A commodity is something that can be bought and sold, and you can get the same type of product from virtually anybody who creates it. Bottled water is a commodity because I don't care what the shape of the bottle is or what the color of the label, it's water. And by the way, I reuse my bottles over and over and over and over. I hate buying bottled water, but I like to buy the bottles. Water is a commodity. Precious metals are a commodity. Oil is a commodity because it can come out of any well, same stuff essentially. Cars, not a commodity. A Ford is different than a Toyota, which is different than a GM, which is different than a Porsche. So, is healthcare a right or a commodity? Do all of you have a right to get the treatment you need or is it something that should be bought and sold? Because right now, it's a bought and sold product. Because the reality is, if you have a sinus infection, pretty much any doctor you go to, you're going to get the same treatment. Oh, maybe this drug instead of that drug. He might do an x-ray. He might do lab work. But bottom line, you're going to get an antibiotic and told to go, you're going to go home and take a Tylenol or Advil for fever, push fluids, rest, take antibiotic complete, and don't stop before the end. You're going to get the same treatment. So which is it? Is it a right or a commodity? Code of Nurses from the ANA says nurses provide care without consideration of social or economic status. So we don't care who the person is or what they can pay or what they can't pay. Is that the real reality? No, of course not. The reality is we do care. Well, we don't necessarily care, but we do let it affect us. Spill water. If you have a person who is homeless and they're always in your ER because they can get some food, maybe sleep for a little while, but they're using up a bed and resources, eventually that's going to start to wear on you. So eventually that person and people like that person will get slightly different reception and responses. It's not fair, but it is reality. Who pays for healthcare? Who should pay? If healthcare is a right, who should pay for it? Ooh, government? Well, businesses? Each person? Huh. Let's think about that for a second. Do you want to pay for your own health care? You can. People have in the past. It's going to cost thousands of dollars, unless you stay very healthy. That's an option. We can make all businesses provide health care to everybody. We could. I mean, conceivably, that is a potential that they could put into effect. All businesses must provide health care. There you go. Problem solved, right? Everybody who's working, oh, darn. What if you're not working? Oh, now what happens? And even if everybody was working, how are some businesses going to be able to pay for that $1,500 a month? If you have a person, if you have one employee, and that employee works at a hot dog stand selling hot dogs, that's a lot of hot dogs that you got to sell just to cover the insurance. So what are you going to do? Well, you can probably increase the hot dog prices to cover that insurance. So who pays? Who's really paying? Your customers. Oh, see, we're back to us paying for it again. We'll just have the government pay for everything. Where does the government get its money? Us. We pay taxes. Bottom line, the reality is whether we pay premiums out of pocket or pay higher prices at the stores or get taxed higher, we pay it. And it's a shell game. And it annoys me when people think that if it's run by the government, it's going to cost me more money. Why can't we just let the businesses do it? Because it's going to cost us money there. It's always going to cost us money. So that was a little rant, but Medicare pays for inpatient stays. It does pay for some outpatient care for patients over 65. Medicare does not cover everything. That's why there are different levels of Medicare. Medicare A, B, C, and D. So and B, C, and D you have to pay for. You have to buy that. So that's that's another who provides, who covers. There are no easy answers. Now there are 3 ways of allocating. Who makes the decisions? Who makes the allocation decisions? There are 3 ways it can be done. You can have the payer. Payer is insurance and the government. They can decide. The payer might put in rules on prior authorization. They might do utilization review. Let me tell you just a couple of minutes about that. Prior authorization and utilization review is what I did for an insurance company. This is how the payer determines where the money gets spent. You contact the insurance company and say, I want to have my gallbladder taken out. We look up in our system, do you meet the criteria? If you do, we say yes. If you don't, we say, you can have it taken out, but we're not going to pay for it. Utilization review does the same thing. Prior authorization happens before the services. Utilization review happens after. That's where we get the claim in, and then we look at the person and say, yeah, we're not going to cover that. Or, sure, we'll cover that. That is a brutal job. It was a good job in that I learned a ton about healthcare economics, but it was really hard making those decisions. But when you have limited funds, decisions on allocation must be made. That's one option. Marketplace is another one. How does a marketplace? Well, the marketplace can do it because they can change consumer knowledge. They can teach people that Humira is as effective as, say, methotrexate. It may not be, but I'm just using that for an example. Marketplace can also make it very difficult for competitors to come to the market. So they can throw up barriers to entry. Lack of price competition is a big one. How much does a gallbladder cost to be taken out? You could call 4 hospitals and they all say the same thing. I don't know. It depends. It depends on what insurance company you have, what network you're in, what doctor you're using, how sick you are, what are the problems you have along with it, do you have any comorbidities? They don't know. They can't tell you. They can give you a range. Well, it'll cost you between this and this. When was the last time you bought a car and there's a price tag that said, it's going to cost you between this and this? Right. Can you imagine that? So since there's no price competition, there's barriers to entry, and they can alter consumer knowledge, that changes how money gets allocated. The last one is the hardest. Rationing. That's a need-based system. If you need something, you get it. If you don't really need it, you don't get it. Some countries have systems like that in place where Canada has an excellent health care system, but if you are not in desperate need, you don't get things right away. If you are in desperate need, no problem, covered. But if it's not critical, if it can be handled somewhere else or just not handled at all, they're not going to give it to you. Here's the thing though. Who makes that decision? Over here, that's the same thing. Prior authorization is another way of doing needs-based allocation. Who's making that decision? That'd be me, based on standardized guidelines that are used everywhere. But I'm still deciding who gets what. So can the same thing be done over here? Sure. They can use a standardized guideline. If you have this and this and this, you get that. It can be sort of black and white. All right, I'm going to stop here. We have one more section, and then we're done.